The role of implantable cardioverter defibrillator, known in short as ICD, in heart failure is primarily centered on the prevention of sudden cardiac death due to ventricular arrhythmias. While heart failure medications improve cardiac function and symptoms, they cannot always stop the chaotic electrical signals that lead to cardiac arrest. The use of an ICD is generally categorized into two primary and secondary prevention strategies. Primary prevention applies to patients who have never had a life-threatening arrhythmia but are at high risk because of their underlying cardiac condition. Ejection fraction less than 35% is the most common threshold. If the left ventricular ejection fraction remains low despite at least 3 months of optimal medical therapy, an ICD is often indicated. Ischemic versus non-ischemic. Patients with a history of myocardial infarction, that is ischemic cardiomyopathy, typically see a more pronounced survival benefit as established by trials like MADIT-2 and SCD-HEFT. For those who have suffered a recent myocardial infarction, guidelines usually require waiting 40 days post-MI before ICD implantation to see if the EF recovers. Secondary prevention is for patients who have already survived a sentinel event such as sustained ventricular tachycardia, ventricular fibrillation cardiac arrest, syncope where a ventricular arrhythmia is highly suspected. ICD monitors and analyzes the cardiac rhythm continuously and provides a tiered therapy approach. If the device detects a ventricular tachycardia, it can pace the heart even faster for a few seconds to break the circuit and return it to normal. This is painless and often goes unnoticed by the patient. This is known as anti-tachycardia pacing or ATP. If ATP fails or the rhythm is ventricular fibrillation, and sometimes for even fast ventricular tachycardia, the device delivers a high energy defibrillation shock. Many heart failure patients also have a conduction delay like a left bundle branch block. In these cases, a cardiac resynchronization therapy with defibrillator CRT-D is used. It combines the shock features of an ICD with biventricular pacing to synchronize the left ventricular contraction, which can actually improve the ejection fraction. Recent data, specifically the Danish trial, has sparked debate regarding the extent of ICD's benefit in non-ischemic cardiomyopathy, especially in elderly patients, suggesting that as medical therapy like ARNIs and SGLT2 inhibitors improves, the relative benefit of ICD may shift. The clinical use of implantable cardioverter defibrillators is guided by several landmark trials that differentiate between ischemic and non-ischemic etiologies. Here are the pivotal trials, their key findings and references. In ischemic cardiomyopathy, the trials established ICD as the gold standard for primary prevention after a myocardial infarction. MADIT-2, prior MI and ejection fraction less than or equal to 32% were enrolled. There was 31% reduction in all-cause mortality versus conventional therapy. Trial published in NEJM 2002. SCD-HEFT trial, NYHA class 2 or 3 plus ejection fraction less than or equal to 35%. There was 23% reduction in mortality. ICD was superior to amiodarone and placebo. Attenuation of ICD benefit was observed after 6 years. That is a recent publication in JACC 2022. Dynamite, early post-MI, 6 to 40 days, no benefit. ICD reduced sudden death but increased non-arrhythmic death early on, NEJM 2004. In non-ischemic cardiomyopathy, data is more nuanced, particularly with the advent of modern guideline-directed medical therapy. Danish trial enrolled non-ischemic cardiomyopathy with ejection fraction 35% or less. No significant reduction in all-cause mortality overall, though sudden death was reduced. Published in NEJM 2016. Danish extended follow-up. Benefit in patients less than or equal to 70 years. Reduced long-term sudden cardiovascular death in those less than or equal to 70 years. There is the recent publication in JACC 2025. Definite non-ischemic cardiomyopathy plus ejection fraction less than 36% and PVCs or an SVT trend towards reduced mortality but did not reach statistical significance. Reduce the risk of sudden death from arrhythmias. Published in NEJM 2004. Modern heart failure management, particularly the integration of the 4 pillars of guideline-directed medical therapy, ARNI, SGLT2 inhibitors, beta blockers and MRAs, that is mineralocorticoid receptor antagonists, has fundamentally changed the landscape of ICD eligibility. The primary role of ICD is now being deferred or even eliminated in many patients due to a phenomenon called reverse remodeling. The most significant impact of ARNI and SGLT2 inhibitors is their ability to improve the left ventricular ejection fraction beyond the 35% threshold, rendering an ICD unnecessary. Pro-HF trial of ARNI demonstrated that sacubitril valsartan leads to significant rapid reverse remodeling. Among patients with heart failure with reduced ejection fraction who met primary ICD eligibility criteria at baseline, 62% improved their ejection fraction to beyond 35% by 12 months after initiation of sacubitril valsartan therapy. Recent evidence shows that adding an SGLT2 inhibitor to an ARNI has synergistic effect on ventricular volumes and mass reduction, further increasing the rate of HF-IMPEF, that is heart failure with improved ejection fraction. SGLT2 inhibitor therapy is associated with a reduced risk of sudden cardiac death in patients with heart failure receiving contemporary medical therapy. Recent observational data indicates a downward trend in primary prevention ICD implantations. In real-world cohorts, ICD implantation rates have dropped by 4 to 5% because patients simply get better on drugs.